Guys, this is Dr. T, and yeah, welcome to Clinical Medicine with Dr. T. So guys, please make sure that if you think that I'm making sense, and if you think that you are learning anything from this channel, please consider subscribing, like and share. And also, if you hit that notification bell, if you do that, then you are gonna get a notification whenever I upload a video, so that you don't miss out on anything. Yeah, so I'm not sure if you guys have been following. The past 2 days I started this series on circulatory failure specifically. So we've been talking about shock. We've defined what shock is and the types of shock, and also how to diagnose it and what immediate treatment you can sort of like start the patient on. And just briefly, we said that the types of shock that we've got distributive, and at distributive we have vasodilatory. And the vasodilatory shock is a kind of shock that you get when you have massive vasodilation in the body. And septic shock, which we are going to talk about today, is a type of a vasodilatory shock, and that's like the mechanism how it happens. And then we have also anaphylaxis. Yesterday I uploaded a couple of videos, I think part 1, part 2, part 3, on anaphylaxis. So we've covered this one, so we're gonna do this one today. So the other types of shock are hypovolemia. We also have cardiogenic, and we've got obstructive, right? So we're gonna do them one by one. We're done with anaphylaxis. Please go make sure that you check that video, those 3 videos out. So let's talk about sepsis here. Septic shock. The next thing about septic shock is that I have had a couple of patients with septic shock, obviously, with dystonias. The next thing about septic shock is that when a patient is just getting into septic shock, or they just still have sepsis, when you pick it up, the patient gets better like immediately. It's one of those things that if you pick it up early and then you manage it, you can go home and say, okay, today I actually saved a life. So yeah, it is common, guys, because infections are very common. So when you talk about infection, now we all know what infection is. It's invasion of pathogens in a place that is normally sterile. Then they invade, and the body responds to the invasion, and then an inflammatory cascade occurs. And that's what infection is. And then so the infection can either take 2 paths. It can remain local until it heals, or it can become systemic. When you see a patient who's got infection, like who's got an infection, if they're gonna die, they are likely to die because of the complications of the infection. Remember, Sepsis, septic shock, those are just the complications of the infection, because not everyone who comes in with infection has got sepsis. Not everyone who comes in with infection has got septic shock. Not everyone who comes in with infection gets into multi-organ dysfunction and death. Not everyone. So it is, those other things are a complication of an infection. There are infections that remain local, and these infections can be treated with oral antibiotics, and then the patient does not need to be admitted. They can even go home the same day. But it's also important to see, what I've got this infection, what are the likely chances that this might progress and actually become systemic? Because from there, that's how you're gonna decide. So if if a patient presents with an infection, and you are sure that the likelihood of this infection spreading to the rest of the systems is unlikely, and at that point they don't have systemic features, you can discharge that patient on oral antibiotics and maybe give them a review date. But if they are already showing signs of a systemic infection, which is sepsis, then they might benefit from being kept and put on more aggressive oral and more aggressive IV antibiotics until they are fine. So the point that I'm trying to drive at this point is that infection and sepsis are two different things. Infection is just localized. But when you talk about sepsis now, you are saying basically that a patient has got an infection and is starting to show systemic signs. Okay, so let's quickly now talk about what are the possible infections that we can have that will actually push us into the complications of an infection, which is sepsis, septic shock, multi-organ failure, things like that. So any infection that you can think of, can cause sepsis, depending obviously on the immune status of the patient, on the age of the patient. So UTI can, pneumonia, in kids, things like otitis media, meningitis, even cellulitis and abscess. What other infections? The most common one that we see, sorry about that, is post-op sepsis. Very common, be it a C-section, be it a laparotomy. I'm sure internal fixation in ortho, so yeah, and what are infections? Things like appendicitis, especially if it ruptured, bowel obstruction that is ruptured, yeah. So the other possible sources of infection would be your iatrogenic causes. This is iatrogenic because there is no patient who performs surgery on themselves. So this is iatrogenic. The other iatrogenic causes are things like indwelling urinary catheter, predispose the patient to UTIs, indwelling IV cannula, intubations, endotracheal intubation, your central lines, things like that. These can be a source of infection and push the patient to sepsis. Yeah, anything that actually is any procedure that is invasive, any invasive procedure, basically, any invasive procedure can cause an infection and push the patient into sepsis. As long as these are still localized in the body, they are still localized, everything is good, everything is fine, easy to manage. But a problem arises when they become systemic. And when you start to have bacteria that were invading a localized area, now they start to get into the blood and give you bacteremia. That's when now you're gonna start to have issues, because once you've got an infection in the wall of the abdomen, it's localized, it's okay, topical antibiotics will do. But now once that infection, once that bacteria starts to enter the bloodstream and gives you bacteremia, it means it can land anywhere in the body. You can have a bacteremia that has got that is not showing any features of systemic illness. The only way to pick it up is by doing a blood culture. But once you've got bacteremia that is actually now giving you systemic symptoms, then that's sepsis now. So which means if you've got a patient who has got some kind of a surgical wound, once they start to have abnormal vital signs like BP, like a pulse, tachycardia, once they start to have hypotension, a tachycardia, a tachypnea, a high temperature. Have you seen have you seen a patient who has got an infection but they don't have a high temperature, they don't have fever? It does happen. That simply means that yes, they've got infection, but they're not showing systemic signs of the infection. So that's still not sepsis. I know if you go to the hospital, you will find that yes, as doctors we use infection and sepsis interchangeably, but truly and strictly speaking, infection is just infection. But once you have got systemic signs, you cannot say a patient who's got a localized infection and then you say that they've got sepsis. It's not sepsis. Sepsis is when now you've got an infection, a source of infection, but now you start to have systemic signs, right? Then that's sepsis. So that's sepsis. And then the minute now you start to move. Okay, before I continue, let me just say, what are the risk factors? Not everyone who's got UTI is gonna get into sepsis. Not everyone has got otitis media. Not everyone has got an abscess. So what are the other? What are the? These are the differentials in terms of the source of infection, right? But now this side, let's talk about the risk factors. If I did a lab, I had just done a lab and I get into sepsis, and then a friend of mine does a lab as well but does not get into sepsis, what could be the reasons why I got sepsis and he didn't? Yes, there's a lot that we can talk about. We can talk about the sterility of the whole procedure, how the surgeons, what just no, just the sterility of the whole procedure, the instruments, all that, and even whether there's an outbreak of some kind of maybe the theater hasn't been disinfected in a long time, so things like that. But now in terms of other factors like patient factors, it can be things like also not being given antibiotics, all of that, and also the dressing techniques, all those things. But now the patient factors would be age plays a huge role. Anyone can get infection, but the older you are and the younger you are at a higher risk. So which means if you've got this young or a old patient who went for a C-section, sorry, not C-section, they went for whatever procedure in theater, so you should be more alert in terms of looking for sepsis than in a normal patient. That's what I'm trying to say. So the age, the immune status, So I'm talking about immunosuppression here. So immunosuppression can be due to HIV, it can be due to diabetes, it can be due to patient who's got some kind of malignancy, or they are on immunosuppressing drugs, or they are just born with or maybe even patient went for a splenectomy. Remember, the spleen plays a very important role in terms of in the immune system, production of complements and that type of a thing. So splenectomy, and also what else? So someone who's got a poor nutritional status. When you have to operate someone who lives on the street, who's homeless, who has got a poor balance in terms of their nutrition, when they are operated, they are likely to get sepsis than someone who's coming from a home who's got food and all of that. So always bear in mind. The alcoholics, and also the list goes on, guys. The list goes on. And also someone who's got other major comorbidities. Because remember, if your body is already under stress from trying to cope with the medical conditions that you already have, and now adding another condition is just gonna deplete the stores faster, and all of that, and coping will just become difficult, right? The list goes on, guys, right? I cannot mention everything. So okay, let's get back here. So you can have a symptomatic bacteremia or an asymptomatic bacteremia. So when you've got an asymptomatic bacteriuria, someone who's showing signs of sepsis, so that's sepsis. Or you can do a blood culture on an asymptomatic patient, maybe for whatever reasons you're doing it for, and then bam, you've got a positive blood culture, and then you ask yourself, what's happening here? Yeah. So now once you move from sepsis, this is where you want to catch them. This is where you want to catch them, because the more you go down this, it becomes difficult to manage and all of that. So when you've got severe sepsis now, what they call severe sepsis, sometimes when you've got a patient, so this thing really needs you as a doctor to be really on the ball in terms of managing and thinking about the possibilities. What can you do for the patient? Like now I'm thinking, if you've got someone who lives in the street, who probably will not have something to eat maybe the entire day or whatever the case might be, so now they've got an infection. Let's say they just have an infection in the hand. The fact that infection is localized, it's just infection in the hand or it's just an infection in the leg, you know that this patient can actually fight off the infection, and then they will be okay on oral antibiotics, so I don't have to admit them. But the fact that they stay on the streets, the fact that they might not have food, they might not take their medication and all that, so you might just admit that one because of that, just to make sure that you give them that IV antibiotics and then allow them to go home later on. Now once you have got severe sepsis, you can actually get into shock, into septic shock. Into septic shock. We are going to talk about how this patient might present, or maybe let's just do it now. So you've got this patient, they come in and then they've got any of these. How will they present for you to say that they might be having a sepsis? So they might have chills. Yes, if they've got a pneumonia, they will cough, things like that. But I'm just talking about the specific things now. They might be very restless, or they might be very sleepy. They will just appear unwell. They might be sweating. They might even have reduced level of consciousness. They might have restless. They might depending which organ is involved. If they've got a pneumonia, they will have shortness of breath, they'll be coughing, things like that. If the infection is in the abdomen, abdominal distension, things like that. But the thing, the patient that we were doing a quick round around 4 o'clock, when I had just started my internship, I was still doing surgery. So I was working with my senior at that time, and then we were just doing a quick round, and we just saw this guy who started to have chills and then started to be sweating and just become unwell. Some might even vomit and all of that. And when we saw this patient, and then she was like, we need to put up an IV line on this patient and make sure that they are getting the antibiotics. And after we gave, and what also he started complaining about is that he was feeling cold. And her diagnosis was very much spot on. So her diagnosis was very much spot on, because after we started fluids, the patient got better immediately, and then we continued with the antibiotics and stuff, and corrected, because the patient was not really getting the antibiotics as they were prescribed. So that's that. So guys, let's meet in part 2 of this. We already have we're already like 25 minutes into this one.